Thank you, Julia. Thank you, the Sturge-Weber Foundation, for this opportunity to create the webinar on Sturge-Weber syndrome, particularly with focus on identifying high-risk babies. So my name is Anna Pinto. I work at Boston Children's Hospital. I'm the director of the Sturge-Weber Clinic here. And I will review with you some aspects of the neurological diagnosis. I have no special interest, commercial interest on this lecture. This historical slide is to point out that Sturge-Weber is a very old disease since the first descriptions of the cases. However, more recently, since 2013, after the discovery of the somatic gene, a new attention to the disease, particularly if you can identify some aspects on how it works and how the symptoms manifest from the understanding from the genetic perspective. This is important to understand that is a somatic mutation, therefore only the cells affected by this mutation will have the mutation. So there is no point of doing blood tests. And it's also very important to know that it's unlikely patients will pass along, and it was not inherited by the parents. This is a mutation that happened on very specific cells during specific time during the development of the embryo. So ultimately, that mutation will affect cell growth, differentiation, and survival, and that's why we will have the full spectrum of what happened to the Sturge-Weber syndrome. Clinically, we can recognize three different forms. We call the classic form when we have neurological symptoms, dermatological symptoms, cutaneous symptoms, right? Or ophthalmological symptoms, complications of the eye. A second form is considered to be when you have the cutaneous manifestation and the eye involvement, which is a lifetime risk. And that's why it's so important to bring this to the attention to parents and kids with a Port-Wine birthmark. But those patients are the ones who are found to have no brain abnormalities. They don't have any signs that the brain has been affected. Another form of Sturge-Weber that commonly called the type 3 is the one that only neurologists will find. Why is that? Because there is no cutaneous manifestation, no risk for the eye symptoms. However, the patients present with seizures, sometimes severe migraines with neurological symptoms. When they have an MRI to investigate why the neurological symptoms, we find all the expected findings in Sturge-Weber on their brain MRI. So we know that the mutation is likely to be there, causing all the symptoms that otherwise you would see on the classic symptom. However, this form is only brain involvement. What I would like to call the attention from the eye perspective is that glaucoma is the most common symptom, but not the only one. Patients can have retina problems and other problems. And what we have learned with our colleagues from ophthalmology, that is a lifetime risk factors. So patients should have their checking to make sure they don't have any abnormalities that needs to bring to the attention to the doctors. It's a very important message. What is new in Sturge-Weber is that some doctors may refer to the Port-Wine birthmarks according to the distribution of the trigeminal nerve. So they call the V1, V2, and V3 distribution. However, what we know from studies published in 2014 is that there is nothing to do with the trigeminal nerve, has to do with the very early division of the cells, when some cells, they have the common origin coming from the brain and coming from the skin. And when they affect the forehead and the upper eyelid, they may have the common origin with some cells coming from the brain. And that's why the high-risk babies are identified by the extension and the location of their port-wine. So if they have a very large port-wine, capillary malformation on their skin that involve the upper eyelid, forehead, sometimes in the midline, or this whole area as described here, upon birth, we can already identify those babies and provide guidance that they need neurological investigation or at least some consultations, as well as the ophthalmological following. What is very important is that when we identify high-risk babies, we need to hold on or hold off our anxiety on having quick answers, early answers, because these may incur in false negatives. So before the age of 6 weeks, a brain MRI could be normal and not necessarily normal, as it was just not identified the abnormalities. So what we would advise for providers and parents to not have MRIs of the brain done before the age of 6 weeks after birth, right? So and just keep in mind that we don't know the right age to image those babies, but at least to wait 8 to 10 weeks to get the first MRI if the baby is considered to be high risk. Unlikely the neurological symptoms will start during that time, so we will still have that window between the identification of the port-wine and the right timing to get the MRI before any symptoms start. Just keep in mind that approximately 25% of patients with those large port-wines will have the brain involvement, so it's not 100%, but it's important for counseling and guidance. So this is just an example of 2 babies that had MRIs done very early, one at the age of 7 days, another one at the age of 4 days. Both babies were considered to be normal MRIs. The parents were falsely reassured at that time, and at the age of 4 months here and the age of 3 months here, the babies developed seizures. One of the babies actually ended up having a surgery for intractable seizures. How bad was the epilepsy? And but given the fact that the very first MRI was considered to be normal. So that's why it's very important to understand the false negatives when the MRIs are not done with proper protocols, and as well as the very early stage. By having an abnormal MRI doesn't mean necessarily you're going to have abnormal neurological symptoms. Some patients may have findings on the MRI that identify them as having Sturge-Weber, but they may not have neurological symptoms. This is very important to understand, so patients will follow along with the neurologist, but knowing that symptoms may not happen, it would be a very good thing. So we will explain this later. What are the facts in Sturge-Weber? So this is a neurovascular disease, right? And the vascular abnormalities is in a part of the brain that tends to be outside of the brain parenchyma, and I'll show you in another image. And also, the MRI can show what we call the deep venous anomaly, meaning like the deep veins can be enlarged already upon birth. And those are the symptoms we're going to try to identify. Those are the signs we're going to try to identify in the MRI. Something very important about Sturge-Weber, it's expected to have progressive changes. So the babies have the first MRI. If they have another one by the age of 2 or even later, we may see some signs of progression. This is expected. So it's important for the parents to understand it's not getting worse. It's just expected things may change and may progress. It's part of the disease. And another very important aspect is that neurological diagnosis doesn't mean necessarily diagnosis of the symptoms. And this is really, really important to identify. So this is the area associated in the image here. So the vascular, so this is the brain and the brain tissue, right? And the vascular abnormality is right here on the area, on the surface, right, of the brain. Because the capillary malformation in this area, the tissue, like the brain tissue, close to this capillary malformation is relatively deprived by oxygen, deprived by good vascular flow, and therefore we can see this tissue suffering from that, right? So this is one of the things that may happen if, unfortunately, the patient have the Sturge-Weber with the brain abnormalities associated. So here we have the capillary malformation, and this is what can happen with the brain tissue from lack of oxygen and lack of perfusion. Okay, and this is the area of the deep venous anomaly that we can see here on this white line right here. This is the MRI, needs to be done with contrast, otherwise we won't be able to identify the capillary, because the capillary malformation has the property of obtain that contrast and highlights the areas that we have this capillary, as I mentioned before, and this is also the deep part of the brain that is also with a contrast. There are other sequences that allow us to see the deep venous. You can see here in this black lines here, those are all enlarged veins. So we can see that from other sequences of the MRI that also allow us to see calcification, which is another finding of the Sturge-Weber. However, the gold standard is the post-contrast MRI. Okay, so at least once during the whole process, the baby or the patient should have one contrast MRI. This is just to show that the images can provide evidences of these progressive changes. So here is an MRI of the same baby in 3 different ages. The left side here showing a normal volume on this frontal part. This is the back part already showing the capillary malformation with contrast and atrophy, which is the decreased volume, okay, of that area. So here is at the age of 6 months, you already see the difference on the frontal lobe, meaning like it's already expected changes. And here it's even more pronounced when the patient reached the age of 2 years. At certain age, which is not well defined at this moment, the changes stop happening. In our practical clinic, for the most part, we notice no major changes after the age of 4. So 4 years of old is considered to be a good age for which we stop seeing progressive changes, but this is yet to be determined. This is another evidences of the deep venous anomaly and calcification from the MRI. So what is important to understand, since I showed the images with progressive changes, it's important to understand that Sturge-Weber is a developmental disorder, which means that the symptoms may be related to the age phase that the patient is in. So infant and toddlers tends to be the most active phase because the seizures tends to happen during that time. We don't know yet the full mechanism for which the seizures occur. It could be from the lack of oxygen, lack of perfusion, could also be from metabolic changes. There are other things that be associated with the seizures. Patients can develop stroke-like events, which the definition of stroke-like events would be an acute onset of a neurological deficit that tends to be reversible. Okay, this could be associated with a seizure. So after a seizure, the patient can continue and remain with some sort of neurological deficit and tends to resolve in time. And this time may be 48 hours, maybe 1 week, maybe even more than that. This is very important to understand, continue to work on the patient's deficits. It's very important to understand that those are stroke-like events. They are not a stroke as we know it with arterial, abnormalities. Another evidences would be something called hemiparesis, which is by definition motor difficulties often seen on the contralateral port-wine area. So if the port-wine is in the right side of the face, the hemiparesis or the weakness would be on the left side of the body. Okay, so this is what we call the hemiparesis. Like I mentioned, we don't know about the nature of those stroke-like events. This has been under a lot of studies, and we try to understand and look for answers on how to prevent them from happening. And you are going to discover that aspirin is one of the things we use for that. And then, of course, because of the stroke-like events, patients tend to have very often CT scans upon arrival in the emergency department, and I'll mention about that shortly. What I would like to call the attention to parents and to discuss with your providers, most specifically with your neurologist, is to provide some sort of seizure action plan. What you should carry with you if you go for trips, if you are in a high risk of going to an outside emergency department that they may not have your neurologist immediately to be consulted. What should you carry with you? So at least you can alert the doctors in the ER about your child's circumstances. So for example, one thing would be to describe what type of seizures. So focal seizures would be like generalized seizures, whether or not the seizures tends to occur in clusters, yes or no, whether or not the patient has been on a status epilepticus, which means like very prolonged seizures that may require ICU admission, because if the patient already had that, this is a red flag. So the doctors in the ER should know that they are dealing with a very high-risk patients, that they should be attentive and be more proactive in trying to control the seizures and potentially admit the patients to the hospital so they can watch closely for the symptoms. There are, of course, the information about daily medications and what has been used for rescue. If the patient used diastat, like nasal medication, or what kind of rescue medications you carry. And occasionally we use intermittent treatment with a medication called category of medication called benzodiazepine. So clonazepam is an example, lorazepam is an example. Sometimes we can use that as a bridge, right? So we can use whenever you make transitions from one medication to another, or you use that with the patient sick or having fevers and you wanted to calm down the abnormal excitability that generates seizures, or if the patient is going for multiple vaccinations, for example, then we know if the baby already had fevers from multiple vaccines, if it's worth it or not to use something like that. This is to be discussed with your provider, but if the patient tends to use that, this should be listed as a part of the plan for this patient. This is just an example. If the patient comes to the emergency department, they should be received a lot of vigorous hydration, because we know that dehydration is one of the important triggers in Sturge-Weber for migraines, for stroke-like events, and for seizures. Of course, there are certain things that are protocols, so they use some rescue medications in the ER, but it's just if there is anything that your provider can already list as their preference, that would be a good chance to express on that kind of protocol. And then last is just an advice that patients with Sturge-Weber, they tend to have something called thought paralysis, which is one of those, the name that is given for neurological deficits after a prolonged seizures or a seizure. And therefore, if this is expected on those patients, they don't necessarily need to have a CT scan. Okay, because otherwise they do more imaging that would be necessary, and sometimes this would hold off more important aspects of the treatment. So I would say that given the fact that patients come to the emergency department and they often receive those, advice from getting CT scan. In our department, in our hospital, we reviewed all the CT scans done in the ER. And we discovered that even the MRIs or the CT scan did not show anything that would change the immediate management of that patient. Okay, so I think that's very important to understand. There was no risk for bleeding. There was nothing that was a major change that would make us change what we need to do for that patient, which means hydration, medication, treat the seizures, make sure the patient is stable. If the patient needs an image, there is a time that you can do this when he's recovered, or he or she is recovered from the acute event. Here is just some general considerations. So there are no contraindications for patients to receive vaccination. So they should be fully vaccinated. As a matter of fact, the disease in patients with Sturge-Weber, even like the flu, could be more could create more problems than the vaccine. So that is a very important thing. However, when the babies are very prone to have seizures, and if they are in the first year of life, we can discuss with your provider about taking the vaccine and spread them a little bit, so to give time for the babies to receive the vaccine, recover from that one, get another one. So if you can spread a little bit the shots, that would be an idea. If you find it is important to keep in mind, the hydration, fever, and febrile illness are the most important triggers for patients having seizures during the first 2 years of life. Under the age of 2 years, often we use the diastat, which is the rectal diazepam. Keep in mind the safety always comes first in babies. They tend to have prolonged seizures, so we need to have those rescue medications in place. And older patients, they can receive the nasal ones. Right, there are 2 in the market nowadays, the midazolam and the diazepam. Here are the names, the commercial names. I have no commercial interest. It's just information, so you can discuss with your provider about if this could be a good option for your child or for you if you're the patient. Aspirin is still controversial. The use of aspirin, you don't have necessarily to use in every patient, but patients with Sturge-Weber syndrome, with stroke-like events and frequent seizures, they may benefit from aspirin. So we often use that when you have bilateral disease, more seizures, even if they have unilateral disease, meaning like one side of the brain only involvement, but if you still have seizures, aspirin might be very beneficial, and stroke-like events. So keep that in mind. When the patient reaches the school age, we start dealing with some learning difficulties. Even though there is no specific pattern identified, we notice that reading difficulties are the most common complaint and reported difficulties. Often we see signs of ADHD. Of course, if there is family history for ADHD, carries even more that risk for having it. Headaches start to become a problem, and the headaches, they can be frequent and disruptive, as well as they can have neurological symptoms associated. It's important to know, as I mentioned before, there is a task force looking into headaches and possible more recommendations about that. There is no contraindications to use medications for pain as prescribed. When the patients get into the age of adolescence and adults, the chronic headaches become really important. They continue to have epilepsy, they continue to have risk for seizures. However, it seems that the way the brain evolves through time make the seizures less frequent as they have during childhood. So what means is that the mature brain still can generate seizures, but it seems to be more calm on that. If the patient is well is stable with their current medication, they should not come off. They should discuss with their provider, even if they don't have any seizures, because the lesion is still there. However, it becomes a less problem compared to headaches, for example, compared to mental illness. So we know our adolescents, our young adults, and our adults, they suffer with depression. They may have other psychiatric conditions that needs to be very, how can I say, identified by providers and caregivers, for the patients, so we can properly address and treat them. Okay, stroke-like events continue to be a problem during that age as well. So what is next in our community, like in terms of the researchers, the doctors, and the Sturge-Weber Foundation? What would be our interest moving forward, and to provide more answers and more ways to help our patients? So first, or at least first in my mind, that I want to accomplish would be to find some biomarkers so we can identify more the high-risk babies, like the earlier phases, the babies that will likely develop seizures, so we can try to prevent the seizures from happening. If there is anything we can prevent the progression of the disease from happening, those are the biomarkers we want to identify. The pre-symptomatic treatment is a tendency that once we identify the high-risk babies and the high risk for seizures, can we treat before the seizures start? Can we treat before the neurological symptoms start? And there is this tendency of doing that by giving anti-seizure medication and aspirin. Depends on how risk are the babies. Understand more about the headaches. I mentioned that several times during this presentation, and migraines, because they seem to be different from headaches on the regular population, even though patients with Sturge-Weber may have stress-related headaches all the same, may have migraines all the same, but it seems that they are in a higher risk of having more complicated headaches, and this is important for us to understand and treat them. Study more about the stroke-like events and how we can treat them and prevent them. Nowadays, there is this study led by Dr. Jeff Loeb about the natural history of Sturge-Weber in general, and one aspect to be noted and be studied is the epilepsies, whether or not the patient should continue on medications, and I hope soon we'll have more answers regarding natural history of the condition. Other non-neurological issues to be attentive would be the overall health of this patient, right? If they're growing properly, we know there are some cases of patients that have been identified with hormonal growth problems, and so they may need to see endocrinologists or other experts in order to identify any underlying problems. Immune system, for example, we wanted to understand if they have they are prone for other conditions associated with the way they respond to the immune reaction. Mental illness, like I said, is not necessarily neurological, but can be associated, can be overlap. But I just want to emphasize how important it is nowadays for us to identify. Those are just like a short about, again, for the early recognition and progression, and we have been actively working into that. What I would like also to emphasize as a possible take-home message, just to hold off your anxiety about having the images so early in the early stage. Wait at least 8 to 10 actually weeks of age. I'm sorry, this is a typo here, would be 8 at 10 weeks of age, not month. I'm sorry about that. First eye exam should be done already during the neonatal period, because it's very important to identify and then continue to follow very closely with the ophthalmologist. Ocular complications are lifelong risk. So even if you don't have that, different from neurology, you may say goodbye to your neurologist at some point if you have no evidence of brain involvement. However, the ophthalmologist should continue for lifetime. And here's the point about neurology. So after the age of 2, if the patient has a normal brain MRI with contrast and all the recommended protocol, if the MRI is completely normal, unlikely neurological symptoms caused by Sturge-Weber will show up later. So once, of course, patients can have headaches, they can have seizures for other reasons. But if there is no signs of Sturge-Weber after the age of 2 years old, unlikely will happen. Okay, I just one addendum. I know there are some publications about adult onset of Sturge-Weber, but those are very likely to be missing cases during childhood because of a lack of proper investigation. No need to hold, this is completely off topic here, no need to stop aspirin during laser treatment. So sometimes we often hear, we are asked about whether or not the patient should stop the aspirin for having the laser. If the patient really needs aspirin, they can continue with the aspirin. There's no problem on stay on the medication. So, you know, and then just to keep in mind that that's a condition that has a very strong potential for pre-symptomatic treatment. So if you hear about babies that are born with high risk, send them to the well-described center so we can provide guidance for those families. And here, I would like just to thank again the Sturge-Weber Foundation for this wonderful opportunity. And I leave here my information. And if anybody notices my accent, it's because I speak primarily Portuguese. So obrigada means thank you in Portuguese. So thank you.
Thank you, Dr. Pinto. This was a great talk, and we really appreciate you.
Thank you. Thank you very much, Julia.